I will never forget that night. My son had graduated maybe a couple years before. I got a phone call from Dylan's dad that said, Dylan has a problem. I've never felt as helpless as I did in those moments. The emotions and the guilt. This is because I've always been a working mom and I wasn't home enough. This has to have been a failure on my part, and I don't know where to take him. And I'm a primary care provider, and I don't know what to do for my son.
It's not necessarily that there's a right here, right now opioid epidemic. It's always been here. Right now, though, there's a unique problem going on, which is the presence of fentanyl.
It started to become incorporated into the heroin supply. Increasingly, it started to come in the form of counterfeit pills. And more recently, we've seen that stimulants like cocaine and methamphetamine contain fentanyl.
It's cheap, easy to make, and extremely potent by volume, meaning specks can be enough to cause a person to overdose.
Every day that I woke up when Dylan was in active addiction was a day that I could lose my son.
I started drugs at probably the age of 15. That was the best you could ever feel. You know, it was like getting the best news of your life, but having that feeling all day long. And then it just progressed and led me down some dark holes. When I got on fentanyl, it just took off. Every second of every day, from the minute you wake up, from the minute you fall asleep, that's all your mind is thinking about.
When I was looking for treatment, it never occurred to me that his primary care provider could help.
Addiction treatment has been isolated from general medical practices for so long, but that's changed a lot in the last few years. Primary care doctors, specialists, subspecialty clinicians, we can all play a role in helping manage addiction. A key thing that we can all do is provide medications for opioid use disorder, which are quite frankly life-saving. There are 3 FDA-approved medications for treating opioid use disorder: methadone, naltrexone, and buprenorphine, sometimes also known by its brand name, Suboxone. We think of addiction as a disease of the brain. There are opioid receptors scattered throughout the brain, and one of the key regions where they're located is in the reward centers of the brain.
When you take an opioid, they bind to this receptor and they fill it up and they make you feel really great, right? And so when those receptors get empty, you need another pill to fill that pocket to make you feel good again.
I was dealing with a crippling addiction of fentanyl and just couldn't do it. I could not work on myself, try to get clean, and try to get a career. I couldn't do it. I had heard of methadone and Suboxone, but everybody always said it's just as bad.
I think medication for opioid use disorder is underutilized because of the stigma. Folks don't understand how the medicine works, and they will say, it's better for me to stay on heroin. If I get on buprenorphine, I'll never get off.
Recovery isn't about what goes into your body. Recovery is about the ways in which you go about your daily life. Medications, as part of treatment, actually help somebody to re-engage in all of those facets of life. That's how medications are treating addiction and why they themselves are not just another drug or not just another addiction. They're actually solving the problems of addiction.
We categorize the 3 different types of drugs for opioid use disorder by agonist, partial agonist, and antagonist.
All of them provide what we call opioid blockade. And so if you use drugs on top of these medications, there's going to be this blunted effect.
A full agonist is methadone, and methadone completely binds to that pocket. It makes you not feel withdrawal.
It's also highly effective at managing cravings, but it can only be dispensed at an opioid treatment program. And typically people have had to sort of go every day in order to receive their methadone dose.
The antagonist is naltrexone. Naltrexone just kind of blocks the receptor. It doesn't fill the receptor at all. It just kind of keeps opioids out of the receptor.
Naltrexone doesn't typically treat withdrawal symptoms, and so this can be a challenge for some patients.
Because it is an antagonist, you're not going to develop a physical dependence on it. What we hear from patients and sometimes families, it just sort of seems like a safer medication. I understand that and want to validate that that's how they're thinking about this. I try to reframe it and think about, like, we should be thinking about the medication that is most potent when it comes to mortality benefit, and buprenorphine is that medication compared to naltrexone.
Buprenorphine is a partial agonist, and so buprenorphine partially fills those receptors.
It can help control cravings and treat withdrawal symptoms.
Buprenorphine can be prescribed right in primary care, and studies show that it's life-saving.
When I started taking the medicine, it kind of gave me a glimpse of, all right, I can do this, because I don't have to worry about the fact that I'm trying to study here, but the only thing running through my brain is drugs, drugs, drugs. Let's just silence those thoughts in your brain.
Sometimes the patient themselves isn't quite ready to stop their substance use. And if they're not, there are lots of things that we can still offer them, even if we're not providing treatment for their addiction in that moment.
Somebody might need years before they're ready to take a step into a more conventional treatment. Harm reduction allows someone to protect themselves and other people. There are a few really core tenets. One, never use alone. That is essential. And if you're using with other people who are using, you stagger your use so that there's always somebody there who can help. Number two, carry Narcan, because you don't know what you might be getting into. And then three, there's a concept called taste your shot and go slow. The idea that when you have a new batch, that you might not be quite ready for how it's going to hit. So take a small amount first and see how it hits before you take the normal amount you would. Those three things can totally save a life. I think they're more important than anything. If you're in a situation where you're concerned for overdose, what do? The first thing is to approach the person and say, are you okay? If they're not responding, call 911 and administer Narcan. Insert it into the nose and sprayed like any nasal spray. It's safe, it's effective, and it's not dependent on the person breathing it in. It's dependent on the nasal passages absorbing it. Then you want to administer rescue breaths to get that oxygen up to the brain. Those three steps can be a way to save a life, focusing on what matters most and what's the most time-dependent part of what's going on.
When somebody has cancer, neighbors show up with casserole dishes and they do everything they can to help support that family. But when somebody in a family has addiction, nobody shows up.
Addiction is definitely a family disease. It doesn't only impact the person that is using drugs.
For family members who are not sure what to do in terms of their next step, I point them to the Partnership to End Addiction. There's really high quality parent guidance, or they can find peer groups for family members in the community.
It took me a long time to realize that this was Dylan's journey and it wasn't for me to fix. And I just had to be there to support him along the journey. And I learned that by taking care of yourself, you help take care of them. Don't give up on yourself. Don't give up on the person you love. Recovery can happen. A beautiful life is waiting on the other side. Just don't give up.